After studying this module, you shall be able to understand what are sudden and unexpected deaths, to know about the various causes of natural deaths, to understand about various cardiovascular causes of deaths, and to know about various post-mortem findings in all these types of sudden deaths. Now let's understand what is sudden and unexpected deaths are. I'll begin with a quote that eyes don't see what the mind doesn't know. To conclude the exact cause of death in sudden unexpected deaths are the most challenging tasks for any autopsy surgeon because of the hide and seek that the causative disease plays with the eyes of the autopsy surgeon. It is thus very much important for a good autopsy surgeon to know in details regarding all the possible causes of sudden unexpected death. The main concentration and emphasis is on the word unexpected component of the whole incident, and 10% of the deaths usually fall into this particular category of all the deaths on whom the postmortem examination is carried out. Natural death means that death of the person is completely due to a disease process and is not due to any unnatural reason like trauma or poisoning. The association of disease with trauma is frequently debated in court of law when in cases of compensation like road traffic accidents or even the question of negligence arises. It becomes extremely complicated when the trivial trauma as such, because of its trivial nature, may not be individually sufficient to cause death, but if the person has been found suffering from some disease, it could have precipitated the death. So that's why it becomes much important to understand for all of us. As per World Health Organization, WHO, the death is defined or said to be a sudden or unexpected when a person not known to have been suffering from any dangerous disease, injury or poisoning is found dead or dies within 24 hours after the onset of terminal illness. That is the WHO definition of sudden unexpected death. The proper study of sudden and unexpected death will obviously include full laboratory investigations like toxicological, histopathological, microbiological, virological, and serological. However, the most important component is the histopathological examination, which may point towards a specific disease and thus helps the certification of sudden natural death. Now let's understand what are the various causes of sudden natural deaths. They can be divided into several causes, several types, depending upon predominantly the system it affects. The most important, of course, is being the cardiovascular system. So the cardiovascular causes are the most important one, and almost half of all sudden deaths are due to the cardiovascular causes. As we know, the normal weight of heart is around 250 to 300 grams. Heart weight above 500 grams indicates definite cardiac pathology, and this heart or the person having this heart is prone for sudden death. Now let's understand what are the various type of pathologies when we talk about the cardiovascular causes. The most important is the coronary artery occlusion. Out of all cardiac disease, the 80% of the cases of sudden deaths are due to coronary artery disease as a result of occlusion of the branches of the coronary artery due to the atheromatous plaque deposition. And as we know that this is the artery which supplies the blood to the heart. The most common site of blockage is within the lumen of the left anterior descending branch of the coronary artery, and that too 2 centimeter away from its origin. 65% of the cases we find this type of finding, that we see there is occlusion of the lumen of the left anterior descending branch 2 centimeter away from the origin, almost 2/3 of the cases. The next common branch affected is the right main coronary artery, which is involved in 30% of the cases, and very less is the circumflex branch, which is found in only in 5% cases. The atheromatous plaque is usually brownish to yellowish in color, and this is seen occluding the lumen of the affected artery, or the 3 branches what I have described. 75% or more narrowing of the lumen is considered to be critical limit and one of the major causes of sudden death. So what does it lead to? Basically, the coronary artery disease leads to acute coronary insufficiency, the myocardial infarction, the coronary artery embolism. It may lead to even rupture of the heart, the myocardial fibrosis, or the pericarditis, that is the covering layer of the heart, that is pericardium, inflammation of the pericardium. What we see in the postmortem examination, when we dissect the heart, what we see is the fresh thrombi. They are usually dark brown in color, whereas the old thrombi are usually yellowish in color. In a case of acute MI, that is myocardial infarction, usually no change is seen in either gross as well as microscopic features within first 4 hours of the attack. So there will be no change in the first hour. Then within next 12 hours, this occasional pallor is seen grossly, and the microscopically, if we examine, the beginning of coagulative necrosis and neutrophilic infiltrates are seen along with the edema fluid. Then within the next 18 to 24 hours, there is increase in the pallor, and microscopically coagulative necrosis continues with the formation of marginal band necrosis. Then the next 24 to 72 hours, gross pallor with some area of hyperemia is seen. But microscopically, there will be loss of nuclei and striation of the cells along with heavy infiltration of the neutrophils. Then by 3 to 7 days, the grossly hyperemic border is seen with central yellow-brown discoloration. So microscopically, there is disintegration of dead myofibers with appearance of macrophages and onset of marginal fibrovascular response. Then by the 10th day of the infarct, there occurs tigroid appearance of the area with alternate band of red, brown and yellow margins, and microscopically well developed necrotic changes with prominent fibrovascular margins are seen. And by the 2nd week, we see the scarring and fibrosis. So by these changes, we can know the timing of the infarction. Further laboratory diagnosis, then there are special staining techniques by which we ascertain the phenomena. The acute MI can also be diagnosed at autopsy table by the immersion of these tissue slides in TTC, that is triphenyl tetrazolium chloride, and a brick red color development in intact area and pale color in infarcted area is seen within 4 hours. Then there is a simple H and E staining, that is hematoxylin and eosine staining of the same. This will show increased cytoplasmic eosinophilia within 8 to 12 hours. The various fluorescent methods like acridine orange stained cryosecretion and eosine fluorescence in paraffin embedded samples are also described, though not routinely done because of the cumbersome process. But also they give very high percentage of false positives as well. Then the frozen section histochemistry is one of the very important parameter or the method that we do, and this can be done by estimating the various blood levels of various enzymes like creatine kinase, where we see the total and MB fraction, then the enzymes like aspartate transaminase, the lactate dehydrogenase, the various troponins, what is called as cardiac troponins, the myoglobins, as well as the C-reactive proteins. Then after coronary artery disease, the second most important finding or parameter of the cardiovascular causes is the myocardial bridging. It is a non-sclerotic anatomical anomaly of coronaries where they run into the myocardium for variable length. And the compression of arterial segment during systole, there occurs more than 70% of the compression, and this leads to acute MI. This incident was first reported by Riemann in way back in 1737 at autopsy and was described angiographically by Portman and Ivig in 1960. Usually it remains asymptomatic and very seldom diagnosed. The frequency to find it on angiography varies from 1.5 to 1.6%, but at the autopsy 23% to 85%. The left anterior descending artery or branch is mostly commonly involved, because this LAD or the left anterior descending branch, left anterior descending artery, is the most commonly embedded artery in the middle half. So some authors also stated that involvement of the proximal half. But then anomaly is pathological when tunneled segment is 2 to 3 centimeter long and 0.2 to 0.3 centimeter deep. As myocardial bridging is asymptomatic, prediction of morbidity and mortality is very difficult. In all sudden death cases, in absence of any other apparent findings, the possibility of myocardial bridging should be considered. This is a pictorial diagram which shows the lumen of coronaries in the myocardium, that is myocardial bridging. Then the other cardiovascular causes, several, there are many. The occlusion of ostium of coronary artery associated with atherosclerosis or syphilitic aortitis, the arterial hypertension with atherosclerosis, angina pectoris, pulmonary embolism, systemic embolism, rupture of aneurysm, various cardiomyopathies, lesions in the conducting system of the heart, aortic stenosis, aortic regurgitation, mitral stenosis, rupture of chordae tendineae, aortic dissection, coronary artery spasm, dissecting aneurysm, fatty degeneration of the heart, myocarditis, sick sinus syndrome, hypertrophic obstructive cardiomyopathy, that is HOCM, and valvular diseases. So the list is very long. Then after cardiovascular causes comes the respiratory causes, and this accounts for almost about 15 to 23% of all sudden death cases. If you see the various causes, or you can say the various types of respiratory system involvement or which lead to death, are lobar pneumonia is one of the very important cause. Then in our circumstances in India, the pulmonary tuberculosis, cavitation and rupture of blood vessel, then bronchopneumonia, bronchitis, pulmonary embolism, air embolism, acute edema of glottis, acute pulmonary edema, bronchial asthma, diphtheria, lung abscess, massive collapse of lung, the neoplasm, that is different type of cancers of lung, the pleural effusion, the pneumothorax as the result of rupture of any emphysematous bleb, or maybe due to impaction of any foreign body in the respiratory tract. Out of these all list of entire causes, the pulmonary embolism is a well recognized complication following trauma, especially surgical interventions and fracture of bones. And this pulmonary embolism may also be found in females who are on oral contraceptives as well as who are pregnant. So, the phenomena of pulmonary embolism, if this situation is there, it needs to be interpreted in a very careful manner. That is, whether it is due to the disease or it is the trauma which has led to the development of the pulmonary embolism. Then third important cause of this system involvement is the central nervous system involvement. 10 to 18% of the sudden deaths are due to central nervous system involvement. Out of this, the epilepsy is the most common cause of sudden death when the CNS comes into picture. And this itself is responsible for 10% of all CNS causes. Usually in the autopsy, there are minimal or no findings at all, except occasional tongue bite marks and the signs of asphyxial deaths. In the respiratory tract, there may be inhalation of the gastric contents, which leads to choking. The victim is usually found dead in sleep, or witnesses may give history of seizure attacks. The clothing must be carefully examined for any evidence of incontinence of urine or feces or presence of vomitus. Another precaution is that blood must be sent for chemical analysis for the estimation of barbiturate levels, as even a known patient on medication is also prone for sudden death in case of sudden withdrawal or maybe overdose. If the death is not witnessed, the diagnosis of death due to epilepsy is based upon thorough evaluation of reliable history, various autopsy and laboratorial findings, as well as excluding other causes. Also, it should be kept in mind that there may occur a phenomena that is called as SUDEP, S-U-D-E-P, that is sudden unexpected death in epilepsy, where there will be no anatomical or histological findings will be there, which occur due to the disturbance in electrical discharges of brain, and this is a well recognized phenomena. The other common CNS causes are non-traumatic subarachnoid hemorrhage, like as happens in ruptured barrier aneurysm, ruptured arteriovenous malformation, cerebral hemorrhage, pontine hemorrhage, cerebral thrombosis and embolism, carotid artery thrombosis, brain abscess, cyst in the ventricles, polioencephalitis, septicemia, the viral encephalitis. Then the next system is the alimentary system. Almost 6 to 8% of all sudden deaths are due to involvement of the alimentary system. And the various types or various causes of the alimentary system are involved. Acute hemorrhage into the GIT from peptic ulcer, from esophageal varices, as well as the acute hemorrhagic pancreatitis. Appendicitis, cancer of esophagus, the perforation of peptic ulcers, amoebic ulcers, typhoid and duodenal ulcers, they also lead to sudden death. The intestinal obstructions, interceptions, the ruptured liver abscess, the ruptured enlarged spleen, the cholecystitis, paralytic ileus, volvulus, gangrene, strangulated hernia, all are the causes of alimentary system involvement. Now the next system is the genitourinary system. 3 to 5% of all sudden deaths are due to involvement of genitourinary system. The most common causes are ruptured ectopic pregnancy, nephrolithiasis, that means the stones in the kidneys, the obstructive hydronephrosis, the pyonephrosis, cancer of vulva with involvement of femoral vessels, chronic nephritis, toxemia of pregnancy, uterine hemorrhage due to fibroids, twisting of ovary, ovarian cysts, the tumors of kidney and bladder. Then comes the miscellaneous causes. The endocrine system involvements contribute to 5 to 10% of all the causes. Other miscellaneous causes include diabetes mellitus, hemochromatosis, Addison's disease, hyperthyroidism, blood dyscrasias, cerebral malarias, vagal inhibition, mismatched blood transfusion, anaphylaxis due to drugs, all these which constitute miscellaneous causes, which will be taken one by one separately. Out of all these, the vasovagal inhibition, of course, is one of the most important entity in all these miscellaneous causes. So let's understand what is that. This is also known as vasovagal attack or the vasovagal shock or the reflex cardiac arrest. It is characterized by sudden stoppage of heart following reflex stimulation of the vagal nerve endings. There is a huge network of sensory nerve supply by various branches of vagus nerve, which is the longest cranial nerve of the body, to different organs like pharynx, larynx, trachea, spermatic cord, cervix of uterus, all those. The most notorious is the carotid body, which is situated at the bifurcation of carotid body right here, common carotid artery, where the common carotid artery goes and bifurcates into the external and internal carotid arteries. There the carotid artery is situated here. So the death due to vagal inhibition is instantaneous and very dramatic in case of vasovagal shock. The sudden pressure over the neck in the region of carotid sinus, this is the carotid sinus, and this occasionally occur in physical restraint during catching by neck hold by the police or mugging or strangulation in a case of homicide, and this leads to vasovagal shock. Here usually there is no intention to kill, but the person dies and the charge of homicide is pressed upon. This sudden blow to abdomen or squeezing of the scrotum or larynx, they can also produce the vasovagal inhibition. So we must consider this also. Coming on to the medico-legal aspects, the issues involved in such situation. To give final opinion regarding cause of death in sudden death cases is literally a challenge to all autopsy surgeons. The surgeon should keep in mind all the important causes and then proceed afterwards. However, the chances of foul play should also be borne, and hence the autopsy surgeon should not get biased. Sometimes a sudden natural death in a comparatively young adult, this creates hue and cry among the relatives of the deceased, and most of the time foul play is alleged or suspected. So it is the expertise of a good autopsy surgeon that all things depends upon that, how he interprets that. The sudden or unexpected death is defined as when a person not known to have been suffering from any dangerous disease, injury or poisoning is found dead or dies within 24 hours after the onset of terminal illness. 50% of all sudden deaths are due to cardiovascular causes. Out of all the cardiac disease, 80% of the sudden deaths are due to coronary artery disease as a result of occlusion of the branches of the coronary artery due to atheromatous plaque deposition. In all sudden death cases, in absence of any other apparent findings, the possibility of myocardial bridging should be carefully explored. About 25% of the sudden deaths are due to respiratory system involvement, primary being the tuberculosis. 15% of the sudden deaths are due to central nervous system involvement, primary being the epilepsy. Then about 5% of all sudden deaths are due to involvement of alimentary system and genitourinary system each. The vasovagal shock is also a defined entity and important reason for sudden death. Thorough histopathological, microbiological and virological examination of various tissues and biological material is needed to confirm sudden natural death. And trauma in presence of any disease needs to be interpreted very carefully.